Hello? Testing, testing. Is anyone there? Testing, testing, testing. Can anyone hear me? Hello. All right, I still can't hear anybody, so is anybody there? Hello, hello. No one's responding on the chat, and I can't hear anybody. I see that there are 3 viewers. And the camera's kind of blurry. It looks like to me. Is camera blurry to you? Okay, so if you have a question, type it over in the chat box. The chat is the blue, it looks like a blue bubble. And if you want to chat in that, you can do that. I also have a question and answer feature that is, apparently it's disabled. So, all right, so any messaging, any chatting you want to put, you can over on the right-hand side. Okay, I see I have 6 viewers. I'm not sure why I can't hear anyone. So if you have a specific question, go ahead and chat it or type it on the right hand, type it so that you can see the chat. I see your stuff now. I have my stuff on silent. Okay, how do I turn my stuff on? Speakers are on at 100%. Okay, I see your chats now. Very good. Question is, how do I hear you? I am going to the help section. Hang on a second. Okay, I'm going to go back to the I'm going to go back to my laptop and I think I can get that to work better. Okay, can anyone hear me now? Okay, I'm going to go back to settings and see if I can figure this out. I've got the sound test. I can hear the sound test. How do I, and I'm going to turn the camera on. Okay, here's the camera. Wild. Okay, and how do I hear you? I hope you're studying during this time instead of waiting for me to figure this out. It was working perfectly the other night, so of course that's what happens. In the control room, turn my sound up. My sound level is up. I can hear the sound on my computer. Okay, I've got it set so that I should be able to see your audio and video as well. Okay. Okay. I still can't hear you. So if you have any questions, please type what your questions are, and I will be watching for those to come through, okay? I don't know how to get it so that you can hear, so that I can hear you. Or here's another thought. We could just start a plain old Google Hangout instead of the Google Hangout on air. That's a possibility too. Okay, Vanessa said, can you tell us if tachycardia is a symptom of hypovolemia? Yes, it is. Good question. When you have a patient who does not have an adequate intravascular volume, we refer to that, yes, as hypovolemia. And tachycardia, since there's not as much fluid to pump around for perfusion reasons, then the heart has to pump faster. So yes, hypovolemia is absolutely one of the symptoms of tachycardia. Is absolutely a symptom of hypovolemia. Okay, very good. Can you guys see me okay? See me and hear me? I know my speakers are working. Okay. So if you have questions, specific questions, go ahead and type them into the chat. I can see the chat. I apologize. Okay, I see that Vanessa said thank you. All right. Good. Can see and hear. Excellent. Okay, Elizabeth said, I can see and hear you. I'm trying to enable my camera and mic. Oh, okay. Great. Javier, Elizabeth, Vanessa, what questions do you have? And if you don't have questions, then I'll start throwing questions your way. Great. Hi, Melissa. It's good to see you here. You're all furiously typing, I'm imagining. I hope that this is helpful today. Sorry for the little delay, the mechanical delay. I thought I could do it from my phone. I like to do Hangouts on my phone, and I thought I could do it from my phone, but I couldn't figure out how to get into my own pre-scheduled Hangout on air. If I'd done it spontaneously, I could have done it. Anyway, okay, questions? Other than metformin and glipizide, do we need to know other oral diabetic meds? Very good. That's a good question. If you will look in chapter 83 in the MedSurge ATI, it has a good quick synopsis about the medications. The main ones I would encourage you to know are, yes, metformin and glipizide, the first and second. The biguanides was the metformin or glucophage. And then, and so the glipizide or the second generation sulfonylureas, and I think that is great. That's plenty. Okay. I'm more concerned that you are thinking about the insulins, the 4 specific kinds of insulins, the rapid acting, which are anything that has Lispro or Aspart in it, the short acting, which is regular insulin, and then the intermediate acting is the third one, which we generally call NPH, and then the fourth one we're going to focus on is Lantus. So those would be the 6 medications that I would encourage you to really focus on. And more specifically, the insulins, okay? For example, how do if I have a patient who is a brand new diabetic, what would you teach them about if they were, let's say they had been placed on 10 units of regular insulin, AC, what would you do to teach them about that, about insulin administration? Okay, so start typing to me what you're going to teach them about insulin administration if they're on 10 units of regular. And that's a lot, but let's say you've got a very large person. 10 units of regular insulin AC. And here's another aspect of it. And specifically what I would encourage you to know about your medicines and the insulins is onset, peak, and duration. So what is the onset, peak, and duration of regular insulin? And what would you teach that client? I look really old here. Adrian, do you mean me asking questions like this, or you want questions like sample questions, like multiple choice questions? Is that what you're asking when you say, can you give us some questions, or do you want me to talk through client care situations like I'm asking you right now about insulins? What would you teach? Vanessa says, you would administer 20 to 30 minutes before meal for regular insulin. That is correct. Peak is 2 to 4 hours. Make sure to eat after you've taken it. No delay in meal. Very good. So the reason that we administer regular insulin a little bit before the meal is so that it can already be at its onset when the meal starts.
So since the onset is at 15 to 30 minutes, so you'll want to 30 minutes is about what you're shooting for. So you want to administer the insulin at about 30 minutes before the meal. And then the problem with that, though, why regular insulin is kind of problematic, is because if a patient has to, they get distracted or they don't get their meal when it comes, let's say they're at a restaurant and their meal doesn't come on time, or they get stuck in traffic and they can't eat when they anticipated. That's what the problem is with regular insulin. So a lot of patients have been moved to the rapid acting insulin. So you take the rapid acting, which is the Humalog or the Aspart, and then as soon as they take the insulin, then they can start eating because it has a really rapid onset. And then generally you want to, it's like the immediate squeeze from the pancreas as soon as the patient has started to eat. Our body says, oh, here's an increase in glucose in the bloodstream. So yeah, I need some, and the pancreas goes, and you instantly have some insulin. So with the administration of the subcutaneous insulins, you have to wait for that to be absorbed into the bloodstream. And since the really important thing I would encourage you to remember is when you're delivering insulin to a patient, don't deliver Aspart or the short acting until the patient actually has their food tray right there. Okay. Good, Adrian. You would need to administer regular about 30 minutes before you eat, and then get the food. In a hospital setting, we're busy, we're nurses, we've got other patients to take care of. So I make sure that the patient has the food there before I actually administer their short-acting insulin. Talk to me about Adrian, you didn't answer me about what kind of questions you wanted. Okay, so let's talk about the different different tests, blood sugar tests, the laboratory tests. All right, so okay, Vanessa, we'll come back to. Okay, good. Well, let's talk about lab tests, and then Vanessa will talk about the complications, the HHS and the DKA. Okay, so laboratory tests. If you ever have a patient, even one time, who has a blood glucose over 200, so that's called a casual plasma glucose over 200, then it doesn't matter if they just ate or if they ate 10 hours ago. It doesn't matter. If they ever have a blood glucose over 200, that's indicative or a diagnostic test for diabetes. If the fasting blood glucose, so let's say you have a patient who comes into the hospital or into the doctor's office and they haven't had any breakfast, and then you draw their blood sugar, so a fasting blood glucose over 126, that's diagnostic. Or if the patient has an OGTT, which is an oral glucose tolerance test, then that's over 200. Then they have, then those are all indicative of diabetes, or diagnostic to say, yes, the patient does have diabetes. So the oral glucose tolerance test is where the patient has a fasting blood glucose level drawn, and then they usually have a 50-gram carbohydrate load. We were talking about that. They drink the sweetie fluid, and then we draw their blood glucose level every 30 minutes for up to 2 hours. And if by the 2-hour mark they're still above 200, then yes, they have diabetes. That is positive for diabetes. The fasting blood glucose, like I said, anytime that they have to go without food or drink for 8 hours and then draw the blood glucose. And if the fasting blood glucose is over what value are they considered diabetic? Anyone? Bueller? Okay, the right answer is 126. 126. So anything over 125. Okay. Let's talk about some more client education. The glycosylated hemoglobin, or the hemoglobin A1C, we want that to be as low as possible. We're shooting for, our goal is 5. 4 to 6 is fine, but the closer to 5, the better the patient is. For a patient who's not a diabetic. Anytime a diabetic can approximate or get closer to what a diabetic's level is, that shows that they have good control. So the hemoglobin A1C is the best indicator of what? Overall blood glucose control. That is correct. So if a patient has good tight blood glucose control, they're keeping their levels low, under 125 on a regular basis, then their hemoglobin A1C should be a lower percentage. It's the best indicator of the average blood glucose over the last 120 days. And it helps us to know how compliant the patient is. Having the patient write down their blood glucose levels every time they test would be great. Some patients don't, but and hemoglobin A1C lets us check on that now. Okay, so what we want is patients to have a good blood glucose level. Tight control is what we call that. Very good. Javier says 126. Good. On 2 occasions, yes, 126. I would understand if you said Bueller. Okay, it looks like we might have a little time delay, so it looks like you might be responding pretty quickly, and then I'm not getting those in very quickly, but that's great. All right, so client education. Let's think about client education for just a moment. If a patient has a diabetes and we want them to stay within the expected range, which is the best protection for complications of diabetes. We want to specifically encourage them to keep their blood lipid levels within control, meaning their cholesterol and triglycerides. If you'll remember, if you looked at that video, one of the ways that patients at the blood lipid level has an effect on insulin resistance. So we want to make sure that blood lipids stay low. And that was on that video that I put out or encouraged you to watch on the overview. Okay, now I'm going to start yawning. We want to, for a patient who has, we want to make sure that their blood pressure is under control so that they have less chance of macrovascular changes. Obviously, the good dietary things, fruits, a diet high in fruits and vegetables, mostly vegetables and whole grain foods. Fruits have quite a bit of sugars in them, so they can have fruits. They just need to be controlled for. Okay, talk to me about diabetic retinopathy. What are you teaching the patient so that they don't get diabetic retinopathy, and what are you checking them for? Okay, so the education, the appropriate education for the patient is, and you're typing that to me right now. I can tell you're furiously typing that to me. Okay, so to avoid diabetic retinopathy, they absolutely need to make sure their blood glucose levels stay in control, that they're tightly controlled. Yearly eye exams to ensure the health of the eyes, protect their vision, wear sunglasses to protect against UV rays. The most important thing is tight control and adequate hydration. Okay, diabetic neuropathy, that's where the patient has, I'm there too with y'all, good movie. Which movie was it? Oh, okay. Javier's talking about that video I asked you to watch. Good. All right. Diabetic neuropathy It is it's progressive. It can affect every aspect of the body. That's one of the reasons why patients have numbness and pain in their hands and feet, mostly in the feet. And we want to make sure, once again, that the patient has tightly controlled blood glucose levels within an acceptable range, and then provide foot care. And there's an excellent section in the ATI book on foot care. It's page 920 about foot care and nutritional guidelines, and that's excellent. They also need to see a podiatrist and follow up with a podiatrist and encourage them to inspect their feet regularly. And then diabetic nephropathy, that's the damage to the kidneys. And so we need adequate hydration, keeping the blood sugar levels under control, and monitoring blood pressure. So that whole cardiovascular aspect is so tightly integrated with diabetes, but right now we're just talking about diabetes. But know that when you get to healthcare too, and you talk about perfusion, pay special attention to the extra pieces of good cardiovascular health that goes along with diabetes. So keeping blood pressure and blood lipid levels under control are really important. And healthy eating, exercise, really important. So the patients, we want to make sure they're avoiding soda pop, avoiding alcohol, like I say, adequate hydration of water. And there is a great video if you go online to your review modules in ATI. There's a video on diabetic foot ulcers and diabetic retinopathy, and it is on page 922 is that media clip when you go to that online source. Okay, great. Now Vanessa asked for it. Let's talk about the complications of HHS and DKA. And there is a really great little table on page 928 in your ATI that I would encourage you to go and look at that. The fruity breath is not present with HHS. And you'll know that because the fruity breath comes from the smell of ketones, okay? So the patient is blowing out those keto acids. And with HHS, that's non-ketotic. HHNK is what we used to call it. It's hyperglycemic. NK standard for non-ketotic. Non-ketotic. Okay, so the fruity breath does come from ketones. Okay, so no, there won't be any fruity breath with the HHS, which stands for hyperosmolar hyperglycemic state. But it's non-ketotic. HHNK is the NK stands for non-ketotic. The people that are most likely to get HHNK or HHS can use those interchangeably, but the new phraseology is hyperglycemic hyperosmolar state, is when they have blood sugars over 600 and hyperosmolarity that leads to dehydration, and there is no ketosis that goes on with it. And it's the gradual onset. It's over several days. DKA is the one that occurs much more rapidly, and let's see. Any condition that increases carbohydrate metabolism, such as physical or emotional stress, illness, or infection. Infection is the #1 cause of DKA, but and frequently infection, when we say illness, that an illness includes an infection. So for example, one of our main problems with patients when they get gastroenteritis, a stomach flu, and they're diabetic, they struggle with keeping well hydrated, and so that's one of the reasons why they go into DKA, is they have an increased carbohydrate metabolism. So what can we do to avoid DKA, or what would you teach a patient? That's why I encouraged you to make sure that you studied sick days. How do you teach a patient what should they do for a sick day? And really important is that they have try to get as many fluids as they can down so that they keep hydrated, and and that they continue with their insulin injections, even though they can't eat. Now, they might not need as much insulin, but they need to keep insulin injections going. Another reason why they have the DKA is because if they have physical stress or emotional stress, let's say a diabetic just received news that a family member died, they might not drink as much, they might not feel like eating, and they're having that that emotional stress. And so our bodies kick out a lot of cortisol and glucagon, and that stimulates the liver to produce more glucose, and they don't have the ability to produce the insulin anyway, so they have a much higher risk of DKA when they have any of those risk factors. Emotional stress, physical stress, illness, infection is your number one cause, surgery, or trauma that require anything that would cause an increased need for insulin. Okay, Vanessa said, I know that glucocorticoids will cause a rise in blood sugar. That is absolutely true. What other drugs will cause that? I would say just your main one is glucocorticoids. Just stick with that one because, and don't forget that you can have inhaled glucocorticoids. So let's say you have a COPD patient who is also diabetic, and let's say we put them on a new inhaled glucocorticoid like fluticasone, then that patient would need to have their blood sugar monitor that, and they might need to bump up the amount of insulin that they would need just by changing their inhaled steroids. So don't forget that they might come in different routes. I know a lot of times we think, oh, just oral glucocorticoids, but don't forget there's inhaled as well. So that's the main, those are the main ones. There are other drugs, but I don't want to overwhelm you. So just think glucocorticoids is a great place to go with that. Okay. Okay, anything else that you want to talk about with diabetes? Any other diabetes questions? And remember with DKA and HHS, we want to make sure we hydrate the patient. And to rehydrate them, we're probably going to use an isotonic solution to do that rapidly and then change over to a hypotonic solution to continue replacing the losses back up to where they need to be. So how do we monitor that a patient's getting adequate fluid intake or that their fluid volume is back to where it needs to be? We'll check skin turgor over the clavicle, kidney function. Are they having adequate urine output? So right there within that first half hour, have they had 15 milliliters out in the first half hour? Have they had 30 milliliters out in the first hour? Are they starting to remember that? Remember, always remember that urine output is a reflection of cardiac output. Okay, so if the patient is perfusing the kidneys, then they'll start to put out urine. Other signs that they're hydrated is that that their blood pressure is adequate. They're not hypotensive or hypovolemic. Mucous membranes are moist. What other signs and symptoms can you think of that a patient is rehydrated, that they're not hypovolemic any longer? Blood pressure. So normotensive, normal heart rate, not tachycardic. Tachycardia is a sign of hypovolemia, like we talked about. And that the urine output is, very frequently we will have a patient, we'll put a Foley catheter in a patient who is in DKA or hypovolemia, either one, just to check on their urine output because we can check on it so much easier. Not that they have a reason, a urinary reason, but that we want to check on circulatory status, and a Foley catheter does a good job of that. Okay, let's say the patient is in DKA or HHS. We want to rehydrate them And then if they need IV insulin, which kind of insulin will you give them? Here's a question for you. So A would be short acting, B would be regular acting, C would be intermediate acting, and D would be long acting Lantus. So if the patient needed IV insulin, which one should be given IV? Okay, I'm still waiting. I haven't seen anything yet, but perhaps I shouldn't wait. Regular insulin, that's right. That's very good. Very good. Only regular insulin is given IV. Do you need to know the number values of osmolarity of blood? No. The normal value is 280. So, no, Vanessa, I'm not concerned that you know that. Melissa, no. Okay, I've got some who have said rapid acting mixed with intermediate, no. And short acting, no. The right answer is regular insulin. Regular insulin. It's a short acting. Yes, that's correct. Short acting, not rapid acting. Okay, so the thing that makes it an intermediate insulin is the isophane, the product that makes it's a protein that makes it cloudy, and we don't want to give cloudy medications in the IV. So never intermediate acting or NPH. Okay. All right. Generally, it's 0.1 unit per kilogram for an IV bolus dose, and then 0.1 unit per kilogram per hour. So let's say we have a patient who's 50 kilos, then we would give them 5 units per hour, which is 0.1 units per kilo per hour. But clearly the physician is going to order that if you're giving IV insulin. I have given IV insulin less than 10 times in my nursing career, and that was for patients who were type 1 diabetics who were in labor. We knew that they were stressed, and we were giving them IV insulin. So that the reason that we did that is because we had them come off of their insulin pump so that we could manage their diabetes during their labor, and because you never know when a patient's going to not be able to manage their diabetes or manage their own pump. And so we just had them take their pump off. We'll manage the insulin administration during the labor. And we were anticipating with this one patient, she was very, very ill. She had pregnancy-induced hypertension. We had her on magnesium. She was an insulin-dependent diabetic on an insulin pump. And we had her take her insulin pump off and said, you know what, we're just going to manage all of your medicines and instead of trying to fool with her pump and see if I knew how to program her pump. So, all right. Okay. Any more questions about diabetes? What education are you going to provide to your patient? I told you that lots of times. Okay. What are your signs and symptoms of hyperglycemia? What are your signs and symptoms of hypoglycemia? So if you came across a patient that was hypoglycemic, what would you see? What are the clinical manifestations of hypoglycemia? Clinical manifestations of hypoglycemia. Let's say patient has had too much insulin. or they haven't eaten enough food for the amount of insulin that they took. What are the signs and symptoms of hypoglycemia? Okay, hopefully you've all typed something, so I'm going to go ahead and say it. Clinical manifestations of hypoglycemia: shakiness. Remember how I told you with the babies, we'll see if they are hypoglycemic. Remember I told you the story of large for gestational age babies. They're kicking out a lot of insulin to compensate for their mother not producing the insulin. So as soon as that umbilical cord is cut, then they don't have that rich supply of blood glucose. So, and they've got the insulin still, so they become hypoglycemic. So one of the things we do is we pull the baby's hands up and we see if they're jittery. So shakiness, cool, clammy, irritable, hypoperfusion, so meaning they have pallor, sweating, headache, blurred vision. So cool, clammy, sweaty, cool and clammy, need some candy. So how would you treat that for a baby? For an infant, you'd give them formula, not just sugar water, but go ahead and give them formula. And if they can't take anything by mouth, then clearly we would give them some D50. For an adult, what are some things that precipitate hypoglycemia? Too much insulin or too much exercise. So remember, when the patient is going to exercise, we drop the amount of insulin that they'll need. And then the patient will have another thing that can cause hypoglycemia is alcohol consumption, because they get dehydrated. And so, alcohol on an empty stomach quickly turn into straight can cause hypoglycemia. Okay, so we want to make sure that if the patient is going to drink, that they drink with food on board so they don't get hypoglycemic. Okay. Let's see. Oh, how do we treat hypoglycemia in an adult client? If the patient is unconscious or they're unable to swallow, so they have decreased mentation or they're confused, then we've got two options: glucagon or IM glucagon subcutaneously or intramuscularly, or we can give them D50 via IV. Okay, so that's an acute case, D50 IV. Once consciousness occurs and the client's able to swallow, then you're going to have them start to ingest their own fluids and carbohydrates. If the patient is conscious and they're starting to get hypoglycemic, and then we're going to provide them with 15 grams of either the glucose gel or glucose tablets, tablespoon of honey, 4 ounces of fruit juice. So that's the half cup cartons of fruit juice. And you're going to keep rechecking them until, we don't want to overdo it. So 15 grams is what we're shooting for. Then remember that a protein carbohydrate snack is the best thing that we can give a patient to keep up their blood glucose. Not just carbohydrates alone, but if you can include some proteins, that's the best way to do that. Okay. Can you think of any other questions, things that you want to talk about in diabetes or glucose regulation? I'm so sorry I can't hear you. Vanessa said, I thought that I read that before working out, a patient would increase insulin to help their muscles get glucose. Am I confused? That is a really good question, because there was a question in IGGI on adaptive quizzing that a patient shouldn't have, it was about insulin usage before exercise. And we want to make sure that, okay, so think this through with me, Vanessa. When the patient is exercising, okay, then they're going to start to need more insulin in the cells, okay? Okay, so they're going to need more insulin so they can get more glucose into the cells. Okay, let me answer Adrian's question really quick. Adrian, an example of a protein carbohydrate snack would be like cereal and milk, something that has protein in it as well. So for example, cheese and crackers. Cheese has the protein, the crackers have the carbohydrates. So cheese and crackers, peanut butter and jelly. Peanut butter would be the protein, and the bread and the jelly are the carbohydrates. Milk and cereal. Milk with the protein and some carbohydrate, and the cereal is all carbohydrate. So mostly carbohydrate. Depends on what cereal you have. If you have whole grain, then you're going to get some protein with that. So does that make sense? If you just have some carrots, that's straight carbohydrate. If you have just a bite of an apple, that's straight carbohydrate. So you want to include some protein in that. Okay? So cheese, peanut butter, milk, those are all excellent examples of getting some protein in with the snack. All right. So one of the IGGY questions in adaptive quizzing said, it asked about insulin usage during or before exercise. Insulin and exercise. Okay. And I went and looked that up because I thought, and what I said is that we should have a patient should have a little increase in insulin. And what I looked up talked about, it said a person without diabetes does not have hypoglycemia during exercise because your body naturally reduces the amount of insulin released. And then when you have increased activity, or you speeds up the rate that you use glucose, so then you would need more insulin. So as far as a diabetic, they need to plan ahead to prevent any unnecessary hypoglycemia during the activity. So exercise so that's the difference. It's planned exercise, planned activity, and unplanned activity. So if the patient has planned activity, planned exercise, then they need to keep the blood glucose. They're going to have a little extra snack before they exercise, so that they don't have hypoglycemia. And then let me make sure I'm telling you this correctly. So if they have planned physical activity, then they reduce their insulin usage a little bit. If they have unplanned activity or exercise, then they'll need to increase their carbohydrates. And so the adjustment is that you don't know exactly how much insulin is going to be needed, but for a person whose diabetes is poorly controlled, that already might be hyperglycemic prior to exercise, then they'll just need their blood glucose level won't rise. And remember that when a patient exercises, they get a cortisol. Their hormones say, "Hey, kick out more sugar," so their liver will kick out some more pancreas and glucagon and glycogen with the exercise. So the patient who is already poorly controlled, they'll just need a normal amount of insulin. But for a patient who is exercising, the type of exercise, then they'll want to make sure that they have a little. The site that I looked at said that they would need to have a little bit less insulin as they prepared for their planned physical exercise. As I'm saying this to you, it still doesn't make 100% sense to me. So I probably ought to go review it again. Because it's still not computing. But what I'm looking at says that principles of exercise and activity is that if you plan ahead, that you should need a little bit less insulin for your planned activity. So anyway, that's probably not as good of an answer as you were hoping for, but that's a good question. I need to go back and review that, because I always thought they need a little extra insulin, because when they exercise, they're going to have that cortisol that's going to kick out more glycogen, so they'll have a rise in the blood glucose. So it seems like they would need more insulin if they're going to have activity. But the website I'm looking at, they said, no, you're going to need a little bit less. Sorry, that doesn't compute. So I'm going to need to go review that. Okay, other than that, it's always good. We should go look up when we don't know when things are confusing to us. So. All right, I did want to touch on briefly in the time that we have left, I did want to touch on bowel elimination. And do you have any questions? And any questions in general? I'm very happy to field any questions that you might have. This didn't need to all be about diabetes, but diabetes can really help you understand the acid-base balance. Okay, so diabetes, DKA, is metabolic ketoacidosis, or is a metabolic acidosis. And yes, we're going to need to hydrate the patient. They're going to have too many acids in their bloodstream because of the lactic acids. So yes, I'm going to have, I need to hydrate the patient. Those are some of the main things that you do for a patient with DKA. Okay, so any questions that you have? Okay. Okay, very complicated. I don't ever want diabetes mellitus. No, I don't either, Vanessa. I'm very sorry. I hope I didn't confuse you on that, but I probably did. And so I need to send out, I need to go. I had thought it was one thing. I went and researched, it was another. It still doesn't make sense to me, so I probably ought to make sure that I go review that again as far as insulin and activity. Other than that, you just keep plugging along. When the patient gets sick, they're going to need their insulin still. If they're hyperglycemic, they're going to need their insulin. If they have periods of high stress, they're more likely to have DKA. So anyway, let's talk about, if you don't have any other questions regarding the diabetes or glucose control, let's go talk about bowel elimination for just a couple of minutes. So we talked about incontinence and retention as far as the concept of elimination. So in regards to the bowel, that's retention would be called constipation. Incontinence would be diarrhea. If you are collecting any specimens, that's one thing I did want to talk about, is the fecal occult blood testing, which is guaiac testing. They need to have that not just one time, but you want to sample from different defecations if possible. Anytime a patient does collect a stool sample at home, it needs to be refrigerated. And then we talked a little bit about stomas, ostomies. So a colostomy would, for example, a colostomy would end in the colon, and an ileostomy ends in the ileum. A loop colostomy might be if a patient had a temporary or a medical emergency. And so that's when you'd have double barrel colostomy. That means that they have one proximal and one distal, and you bring both of those up to the surface of the abdomen. And then the patient, ideally, after the bowel has healed, time has gone by, then they will do what they call take down the stoma, and then they'll take those two ends of the of the ostomies, and they'll reanastomose them, put them back together, put them back inside the patient. So anyway, those are what's called double barrel colostomy, one proximal, and so out of the one on the proximal side, so it'll go from the mouth, stomach or esophagus, stomach, down through the small intestine, and then up, and that's the one where you put the pouch on it, and you'll see the stool content coming out of that. The other one is what we call a mucus fistula, and that just means that the mucus, it's just producing mucus. There's not going to be any stool coming from that, obviously, and then it connects to the to the rectum. Okay. For bowel elimination, I would encourage you to know the norms. So, for example, if a patient, let's say you have a breastfed baby versus a formula-fed baby. So with formula, they're going to have more brown, pasty stools, and with breast milk, they have more watery, yellowy, looks like mustardy stools. So those are normal. Those are the normals. A child should be able to control the bowels basically between 2 and 3.5 years of age. Our goal for fiber is 25 to 30 grams per day. There's kind of a false perception out there that one bowel movement a day is the normal. Just depends on the patient. You know, some patients go several times a day and others only go once every 2 days. It just depends. Truly, I think it really depends on their fluid and fiber intake, and then their genetics. Normal defecation, it should be painless. Remember, when a patient is pregnant or has had surgery, that peristalsis is generally slower. With surgery, especially when they have general anesthesia, they might have what we call a paralytic ileus, meaning that the bowel sounds, the peristalsis is slowed, and so we don't want to introduce foods or any fluids until the bowels wake up from their general anesthesia, which takes them a little bit longer. So there's a slowing of the intestinal activity, and then a paralytic ileus is when foods are introduced too quickly and the bowels haven't awakened, and then they can have some constipation with that. Also, opioids can cause constipation. Not enough fiber in the diet can cause constipation. So we would give, and I would encourage you to go and look at your laxatives, the different kinds of laxatives. There's 5 different kinds of laxatives. You've got bulk laxatives, you've got osmotic. We'll come back to that in a minute. Different diagnostic tests. You might have a colonoscopy where they go in with a scope, or a proctoscopy, go in through the rectum and go and look with a camera and a light source. Sigmoidoscopy, all of those are the same thing, going in with a light source. And patients usually have those under conscious sedation. It's remember, the patient would need a bowel cleanse before they do that, so they would have clear liquids for 24 hours prior to a colonoscopy, and then have a bowel, and then drink a laxative preparation before they, so that their bowels are completely cleaned out. There's absolutely nothing in it other than but nothing. Okay. Let's see. Oh, another thing that's really important as far as bowel elimination is making sure the patient has adequate activity. So, for example, a patient who's had surgery, whether it's not bowel surgery, but some type of surgery, who's had general anesthesia, let's say they have had abdominal surgery, maybe an appendicitis. We put them to sleep with general anesthesia, and then the patient, we want to make sure that activity will get them up and get them mobilized, walking as soon as we can, so that it helps to wake the bowel up as well. So adequate activity is also important for to prevent constipation. Um, any questions that you have? We've talked about one of the things that may very well be on the ATI test is something to do with a cleansing enema. I know that you might have learned about that in CNA school. The whole idea behind there's several different kinds. You can use a tap water, which is very hypotonic. That will deplete the sodium. Another kind of enema is soap suds. That's just the soap acts as an irritant and says, hey, get these valves going. Saline is the very safest one. It just provides volume and it's isotonic. So that's probably your very safest one, is a saline. If a saline enema, if the patient has a hypertonic, that would be like a Fleet's enema, or that causes a lot of water to draw into the bowel from the interstitial fluid, and then those work very well, but you just only want to use a very low amount of volume and then have the patient rehydrate after that. The longer the patient can hold the enema, the better off they are. Let's see. On the fundamentals exam, they might very well have something about the ostomy. It's important to keep the skin around the ostomy clean and dry. Apply the skin barrier. You're going to learn more about ostomies in Clinical 3, and all about ostomy care in Clinical 3. But the important thing I would say is observe the skin, make sure that the skin is clean and dry, and that there's a barrier. It's not barrier cream, but it's called paste that is applied so that the skin around the ostomy does not break down. Okay, if a patient has an impaction, that would be stool that's wedged into the rectum, and frequently what they'll have is they'll have diarrhea leaking around the impacted stool, which seems kind of counterintuitive, but what you'd have to do is go in with a gloved, lubricated finger and loosen up the stool, and then it might need to come out in small pieces, and we have to be careful of vagal stimulation. Anytime that the patient bears down, that's called a vagal stimulation, and that can cause the heart rate to slow. So that's the problem with that Valsalva maneuver and Valsalva maneuver. Okay, so issues with complications with diarrhea, we want to make sure that the patient has plenty skin care, and you always want to treat the underlying cause. With almost everything in nursing, we always want to try to treat the underlying cause and then treat the symptoms. So treating the underlying cause, well, what is it that's causing the diarrhea? Are they abusing laxatives? Do they have a gastroenteritis? Medications to prevent or to slow the peristalsis down, and then keeping the skin clean and dry and moisturized specifically. And the same with any fecal incontinence, is to provide a moisture barrier. Whether it's a little baby that has diarrhea, we want to provide an ointment, and specifically a moisture barrier ointment. Let's see. Let's talk about hemorrhoids, flatulence. Hemorrhoids are those dilated blood vessels, basically varicose veins that can come because of difficult defecation or pregnancy. One of the things I heard lately is that they're having an increase in hemorrhoids now with smartphones, because people spend time on the toilet while they're waiting to do their business. They spend longer than they normally would because they're distracted with whatever's on their device. So there's an increase in hemorrhoids now. Yeah, the digital age is even causing an increase in hemorrhoids. Okay. What is steatorrhea? Steatorrhea, Steatorrhea. Steatorrhea is an increase in fat in the stools. A patient who has steatorrhea is not processing their fats correctly. Treatment or recommendations for diarrhea. What are you going to teach the patient to eat or do while they're having that diarrhea? Is to have the patient eat yogurt or something that will help reflorify the bowel. Yogurt or a probiotic. Patients frequently, when they're on antibiotics, can get diarrhea because the bowel, the good flora is killed off, and so the patient will have antibiotics will cause that diarrhea. So pretty common when you have a patient who goes on an antibiotic. They'll need to be taught to have an increase in probiotics or healthy bacteria like that would come from yogurt. Okay, good. Melissa's still here with me. I've got let's see. For constipation, lots of fluids, lots of fiber, different kinds of I would encourage you to go back and review. You could go to the the pharmacology ATI and look at your different kinds of laxatives. But I would encourage that. Nurses caring for a client who will perform fecal occult blood testing at home. Which of the following information should the nurse include when explaining the procedure to the client? And your choices are A, eating more protein is optimal prior to testing. B, one stool specimen is sufficient for testing. C, a red color change indicates a positive test. And D, the specimen cannot be contaminated with urine. Which of those should be included when you're educating the client? A is eating more protein is optimal prior to testing. B, one stool specimen is sufficient for testing. C, a red color change indicates a positive test. And D, the specimen cannot be contaminated with urine. And the correct answer is for fecal occult blood testing at home, the stool specimen cannot be contaminated with water or urine. On the little card, the blue color indicates that it's positive for stool. Clearly, if you saw red in the stool, then you've got blood in the stool. You don't need to do fecal occult blood testing. It's not occult anymore. It's obvious. You have to do 3 specimens, 3 different bowel movements, and if the patient has a lot of protein, then that can alter the test results because it's looking for hemoglobin. That's correct. Okay. Good. So we're basically we're basically out of time. If you have any other questions, I'm happy to go over those with you. Anything that you've been studying and you have a question about, that you're concerned about, that you just totally that you'd like some clarification, now's the time to type those, and let's make sure we get those out. Can you guys see my screen, or just, you can only see my video, right? You can't see my screen because I didn't do screen share, is what I'm thinking. Questions, questions, questions. Last chance on questions. Questions? Okay, I have a couple for you then as we end off here. I have I have one for hypovolemia. If the hematocrit is increased, why would you give a blood transfusion? Is that to increase the volume quicker? Okay, so if a patient is hypovolemic, we will give them fluids for sure, but a blood transfusion would also be helpful. Just because if they're hypovolemic, they probably have a dilution and they might not have a high enough. Okay, let me read it again. If the hematocrit is increased, why would you give a blood transfusion? I don't think that you would. If the hematocrit is increased, they wouldn't need packed red cells. So if the hematocrit is decreased, then yes, you would give, if the hematocrit is increased, why would you give a blood transfusion? If they're severely, okay, Melissa, my response to that is if they are severely decreased or very hypovolemic, very volume depleted, you will see that the hematocrit does increase. And so, but I think as far as in practice, we would give them fluids first, and then if their hematocrit, once they're rehydrated, is decreased, then we would give them blood. Clearly, if you're in a trauma situation where and patients lost blood, then you're always going to give them blood. But that's just, I would say that's a little confusing. What if you've read that somewhere? Okay, I have another question for you. I have a couple of quiz questions for you then. Okay. When is the highest risk time for hypoglycemia with any of the insulins? That's a good thing for you to go look up. When would be the highest risk for hypoglycemia during any of the insulins? So let's say you have an overweight client and they ask why weight loss will reduce the risk of developing type 2 diabetes. What would you say to them? What would be a reason that an overweight man asks why weight loss will reduce the risk of developing type 2 diabetes. Which of the following responses by the nurse is most correct? Excess body weight impairs the body's release of insulin. Thin people are less likely to become diabetic. The amount of food taken in by those who are overweight requires more insulin to adequately metabolize them. Or the physical inactivity associated with obesity causes a reduced ability for the body to produce insulin. Which one of those? Good questions. Good questions. And if you said the excess body weight impairs the body's release of insulin, that is correct. Okay. Sorry, I didn't mean to get back on diabetes. I'm a little focused on that. Let's say that a patient, okay, here's an example. Let's say that a patient had ingested, let's say they have, they had an overdose, okay? They overdosed on some pills. And we go in and do a gastric lavage. That means we go in and put fluid down and we pull the we're trying to suction all that it's like washing the inside of the stomach, okay? That's what a lavage means. It's like washing. So let's say we put a bunch of fluid down an NG tube, we put a quart of water in there, and then we suck it all back out, trying to get all of that medication out, okay? That'd be a gastric lavage. What kind of fluids, if we did that with tap water, what would be the consequence of that? If we did that with tap water, what would be the consequence of that? And then surge 474. Okay, so the consequence of using tap water would be the same as with the tap water enema, right? They would deplete their electrolytes because that free water without any electrolytes, it's very, very hypotonic. Tap water is hypotonic. So the electrolytes from the cells surrounding that would be pulled into that, and so we'd have an electrolyte depletion. So anytime you put tap water in and nothing else, then you're going to start to have an electrolyte, a depletion of electrolytes. Okay. All right. So what would you want to use for a gastric lavage? Not sterile water, not hypertonic, but you would want to use an isotonic solution. Isotonic solution. Isotonic being like normal saline. Okay. If you use D5W, that is isotonic going in, but as soon as the glucose is metabolized, then it becomes hypotonic. So not a great thing. Not a great. That provides with a lot of. That gives us a little bit of calories and mostly free water. So, okay. Metabolic alkalosis. That's right. Very good, Javier. Metabolic alkalosis, because the patient would, we would be pulling all of the acids, the hydrochloric acid out of the stomach. So yes, true. Very good. That was great. Metabolic alkalosis for that patient. Ringer's lactate. Yes, that's another good option. Good. All very good. So you're thinking about your fluid electrolytes and the acid-base piece going together. Okay. Let me throw another question at you. Okay. Okay, let's say that you have a patient in the emergency department and they've got vomiting and diarrhea for the last 4 days. And the patient is 154 pounds. Okay. Okay, so basically what I would like you to know is that a patient needs to, normal urine output is 0.5 milliliters per kilogram per hour. 30 milliliters, yes, without calculating anything, we're shooting for 30 milliliters, but a patient who has adequate volume and adequate kidney function, they should be putting out about 0.5 milliliter per kilogram per hour. So if the patient weighs 150 pounds, that means they're basically 70 kilos, 75 kilos, and so they need to be putting out roughly 35 milliliters per hour. So 0.5 milliliters per kilogram per hour is what we're shooting for a patient's urine output, to make sure that they have been rehydrated. So that would let us know that the patient has been rehydrated. Okay, Melissa, would you specifically send me your question about the, I can see here laboratory test, hypovolemia, and increased hematocrit, and I can see that here, but if you would send that, your specific question to me, what you're looking at. Okay, I need to go. It's been so much fun. I hope that you all are doing well, and that you, if you have any questions, the discussion board would be a great place to put those. I have put lots and lots of things on the discussion board for the review that will help you. It's been on there for quite some time. I looked at it again late last night, as I was preparing, and I thought, you know what, this covers a lot of the things that are on the test. Um, there's a section in there about hypo and hypoglycemia, hyper and hypervolemia, and then all the hyper and hyponatremia, kalemia, calcemia. So I think that's an excellent place to go for all of those electrolyte and fluid types of things. And remember that glucose is considered to be one of your electrolytes as well. If I can help you in any way to prepare, any other way to prepare, please let me know. I will do my very best to support you. I really want you to do well on this test. It's not going to be easy. This content is not easy. I just really hope that you are focusing and that you're taking the time to study and work through that. Okay, so if you have any other questions, please let me know, and I will talk to you later. Thanks. Bye. You're welcome. Javier said thank you very much, and Melissa, you're going to email me. Okay, great. Very good.